Aortic stenosis is one of the most common valvular heart diseases, characterized by narrowing of the aortic valve, leading to left ventricular outflow obstruction and progressive heart failure if untreated. Early recognition in primary care is crucial for timely intervention. 1. Epidemiology. Prevalence increases with age. Affects approximately 3% of adults over 75 years. More common in men than women. Major causes: O. Degenerative calcific disease. O. Congenital bicuspid aortic valve. O. Rheumatic heart disease. 2. Pathophysiology. Progressive narrowing of the aortic valve due to fibrosis and calcification. Increased afterload leads to left ventricular hypertrophy. Diastolic dysfunction and reduced cardiac output develop over time. Severe stenosis eventually causes heart failure, syncope, and sudden death. 3. Clinical presentation. 1. Exertional dyspnea due to reduced cardiac output. 2. Angina due to increased myocardial oxygen demand. 3. Syncope, often exertional, due to fixed cardiac output. Once symptoms appear, survival without intervention drops significantly. Angina, approximately 5 years. Syncope, approximately 3 years. Heart failure, approximately 2 years. For physical examination, classic murmur, harsh. Crescendo to crescendo, systolic murmur at the right upper sternal border. Radiates to the carotids. Murmur increases with squatting and decreases with vol. Other findings: diminished and delayed carotid ups, soft or absent S2 in severe cases. B. Paradoxical splitting of S2. 5. Diagnosis in primary care. A. Initial evaluation history and physical exam. Identify symptoms and risk factors. Auscultation. Detect characteristic murmur. Diagnostic tests. Echocardiography. Gold standard O measures valve area. U severus. Valvaria e menarche un centimetro quadrato. Mean gradient, greater than 40 mmHg. Electrocardiogram O shows left ventricular hypertrophy. Chest X-ray O may show aortic valve calcification or BN. O, elevated, in advanced disease. Suggests worsening heart failure. 6. Severity, classification. Severity, valve area. Mean gradient peak velocity. Mild greater than 1.5 23.0. Moderate 1.0 to 1.520. 43.0 to 4.0. Severe less than 1.0, 44.0. 7. Management in primary care. A. Asymptomatic patients monitor with echocardiograms O mild. Every 3 to 5 years, O moderate. Every 1 to 2 years. O severe, every 6 to 12 months. Aggressive risk factor modification. O control hypertension. O manage hyperlipidemia. O encourage exercise. Unless symptoms develop. B. Symptomatic patients, or severe as referral to cardiology for valve replacement, surgical aortic valve replacement. Preferred in younger. Lower risk patients. Transcatheter aortic valve replacement. Preferred in older or high-risk patients. Balloon valvuloplasty. Medical management, avoid excessive vasoconstriction, as these can lead to hypotension. Diuretics cautiously can help with congestion, but may reduce preload too much. Beta blockers cautiously. Avoid excessive bradycardia. 8. Special considerations. A. Aortic stenosis, in elderly. Most common degenerative calcific aspect, often presents with atypical symptoms. C. TAVR, preferred. B. Aortic stenosis in young adults, often due to bicuspid aortic valve. Screen for associated aortic aneurysm or requires lifelong surveillance, even if asymptomatic. C. Severe AS increases maternal and fetal risk, requires cardiology evaluation before conception. 9. When to refer to cardiology, all symptomatic patients. Severe AS, even if asymptomatic. Rapid symptom progression or new ECG changes. Young patients with bicuspid aortic valve. 10. Key takeaways for primary care. Listen for a systolic murmur at the right upper sternal border. Monitor asymptomatic patients with serial echo. Recognize red flag symptoms. Refer severe AS or symptomatic cases for valve replacement. Manage comorbidities but avoid excessive vasoconstriction.